Good afternoon, folks, or might be good morning, or it may be good evening, or possibly a very good night for to everyone. We are very honored to have you back online. I remember my time running webinars after webinars after webinars for Gulf Pain School, followed by Leicester Pain Education, and now we are on a completely different platform, which is Pain Talks. So what I'm going to do, uh, whilst Professor Lam loading his sort of talk, I'm just going to do a quick intro talk, and what we will do after that, we will straight dive in without any further delay, because I gather majority of the people who are joining do have commitments Sunday evening, so getting ready for the work for Monday morning, so we won't be long. Stan, if that's okay with you, I'm just gonna quickly take over the screen share and then just run through a quick intro presentation, and then after that we will straight go into the talk. Okay, so whilst I'm doing that, if you if you can allow people in to the chat room, from chat room into the Zoom room, that'll be useful. Okay, so guys,
Okay.
so my name is Dr. Sadiq Bayani. I'm a consultant in pain management, or what I would say a staff physician in pain management at Cleveland Clinic in Abu Dhabi. I used to work in Leicester in the United Kingdom. And, I welcome you all to Pain Talks. This is our sort of first session of Pain Talks, an inaugural session of Pain Talks, and I'm going to run through a few housekeeping rules and few announcements, and then we will start with Professor Lam's presentation. Right, so once again, welcome to Pain Talks. So we are very honored to have Professor Stanley K.H. Lam on the first talk for Pain Talks, titled as Emerging Concepts in Pain Medicine. And, you already looked at the intro video of Pain Talks. So Pain Talks is basically aimed at spreading education, peer education,
kali ini aku mau makan ayam anak. Jadi biasanya orang Tionghoa di Bangka, kalau ibu habis melahirkan suka mengkonsumsi ayam masa anak untuk memulihkan stamina tubuh setelah.
So let's go back. Sorry guys, as I said, it's very important that you mute yourself, otherwise it just disturbs the whole flow of the meeting. So he's a clinical associate professor in the Faculty of Pain Medicine of the Chinese University of Hong Kong. He's a president of Hong Kong Institute of Musculoskeletal Medicine. He's a founding president of MSK US Asia Pacific. He's done a lot of research, published a lot. He's published a lot on ultrasound-guided hydrodissection of peripheral nerves and deep nerves. He's also well known for dynamic MSK ultrasound scanning of different joints and nerves. He's written a lot on ultrasound in spine, especially thoracic spine, and he's recently published a very good paper on cervical spine and management of discogenic pain and the regenerative medicine. And he's well known in the field of regenerative medicine for sports injury, musculoskeletal medicine, and chronic pain medicine. So he's done a lot of work, and we are very, very honored and very glad to have him on Pain Talks. Now, moving on to next, what's lined up next on Pain Talks? So, you know, if you haven't checked out this app, this is a very good app for MSK. Stan has done a lot of work on this, and it's a really excellent app. So do check out on the App Store or Google Play. Just type in MSK ultrasound knee, and then you will come across this app. A really great app, a really good resource. And Stan has given a very good structured stepwise approach how to scan the structures in the knee. So next one we have, next Sunday, we will have Prof. Admir Hatzik, all the way from Belgium. He's the founder and heart and soul of NYSORA, New York School of Regional Anesthesia, for those who don't know about NYSORA. And he will be giving us good talks, two great talks, one on building teams and the other one on future of learning. So you know, do register for this. Already put the registration link on the Facebook page of mine and also on the Pain Talks Education Facebook page. If you haven't, you know, signed up for the Pain Talks Education page, do go on the Facebook and just type in Pain Talks and do subscribe. You can also subscribe to the YouTube channel, because we will be putting the videos and upcoming events, also various resources on the YouTube channel. Next we have Prof. Reda Tolba from Cleveland Clinic Abu Dhabi, who will be presenting on neuromodulation basics on 4th of September. Then we have Dr. Georgios Matis, all the way from Germany, talking about history and future of spinal cord stimulation on 11th of September. And then we have Dr. Tony NG from Australia, talking about neurolysis of major joints. Are we there yet? So a very interesting talk, and I look forward to listening to Tony's view on this, which is a game changer in managing major joint pain. And then we have Dr. Amar Salti giving talk on neuromodalities of headache and facial pain management. And then all my colleagues at the Cleveland Clinic in Abu Dhabi, Dr. Amit Verma, who will be presenting on shoulder pain. What's next on 13th of November. My colleague Dr. Jaya Batra will be talking on pelvic pain, a team game. And then we have Dr. Himanshu Chauhan, who will be talking about chronic widespread pain and pain syndromes on 27th of November. So we have quite a lot of good talks lined up. In regards to the events, you know, few announcements. There is an event coming up in Budapest in Hungary on 25th to 27th of August, which is the 11th World Congress of World Institute of Pain, a good event to attend. Another event in September is the IASP 2022 World Congress in Toronto in Canada. And then we have another event lined up for you guys, close to my heart. I worked in Leicester and founded Leicester Pain Education and ran the first international conference last year. My colleague, Dr. Mahesh Kodiwalasa, will be running the second international conference on ultrasound in pain medicine, regenerative medicine and peripheral neuromodulation on 8th and 9th of October. And we're very, very honored to have Professor Bernhard Morgel, all the way from Austria. He's a professor of anatomy and a very well-known father of ultrasound in pain medicine, I must say. He's done a lot of research, and we're very, very honored to have him. This meeting is recognized for 10 CME or CPD points. So do join us at the race course in Leicester in October on 10th, 8th and 9th. And this is a quick intro video for the Leicester Pain Education and NYSORA meeting or conference in Leicester. So that's the announcement for the event at the NYSORA in Leicester. If you guys want to register for that, go onto the nysora.com and you'll be able to find the registration details. So, as I said, we are very honored to have Prof. Morgul, who will be basically there to teach us about hands-on workshops on ultrasound in pain medicine and peripheral neuromodulation. So that's all from my side. I really thank you guys for tuning in, or I would say joining on Zoom. And now, without a further delay, I'm going to hand over the screen share to Professor Lam. So Stan, the stage, or I would say computer, is all yours. You can take over from here.
Thank you, Dr. Sadiq, for the kind introduction and invitation for me to share with all the doctors here around the world about the emerging concepts in pain medicine. And something of
sorry, Stan, the recording is going on, so do apologize.
Okay, no problem. Okay, so I'm the author of an NYSORA MSK ultrasound knee app, and you're welcome to download that, and then you can give me feedback and then how to improve that. We are regularly updating that and try to increase more case scenarios and the real case scenarios and how to treat that in the update. So do give me feedback about that. And then it's step by step, very detailed sonal anatomy and also sonal pathologies of the knee joint. And I would like to dedicate this lecture to our God, to my Father in the heaven, and to my wife for their continued support and keep reminding me to be a righteous person, and to all my teachers, including those silent teachers. A lot of skills we developed from those silent teachers. So to all the doctors listening to this talk around the world, and to all my patients. And for when I was preparing the emerging concepts in pain medicine, I think about how we can identify pain generators. But I have to remind you, pain generators may not be the root causes of pain. So we found the pain generators, we stopped the pain from generating, but we still have to find what are the causes of those pain generators. So that's the root cause, when we have to deal with the root cause. And we also would like I would like to try to balance I would say traditional Western medicine, we are talking about catabolic treatment, using NSAID, using steroids to block or radiofrequency ablation, and then try to block and stop the pain. So that's, I think, is one part of the treatment, especially when you're dealing with cancer patients with end-stage senile persons. But when you're dealing with young or just other normal populations, try to think about anabolic therapy like a regenerative pain medicine, hydrodissection, pulse repetitive, pulse radiofrequency ablation, or new nerve stimulators. And then all these are anabolic treatments. And we also have to think about when we are trying to treat patients' pain, what are the targets we are going to treat? And I would like to cover a bit about regenerative injection therapy. So as Dr. Sadiq has talked about, next few weeks, you're going to see, next week, in fact, you're going to listen to Professor Amir Hazik's talk, and he's the founder of the Nysora platform, and also he's going to talk about how to build the teams. We need a team of doctors to treat and then to enhance our skills and knowledge in treating different difficult pain situations or conditions. And then he's going to talk about the future of learning, which I think Nysora has built up a very good platform, which you can utilize that to improve your skills and knowledge, especially when you're talking about musculoskeletal pain and chronic pain and nerve pain. And of course, my friend Tony and is going to talk about neurolysis of major joints. And Giorgio's from Germany is going to talk about spinal cord stimulation, which I think for some group of patients, this is a very important treatment. And this is also not to break down something, and it's going to stimulate and trying to, I will say this is still anabolic. So I will try to concentrate on the anteromedial knee pain. If we have time, I can go to a bit of the interscapular upper back pain, which are very two common conditions in our daily practice. So for pain generators identifications, I would advocate we use dynamic ultrasound, dry needling, nerve stimulators, nerve blocks, or nerve hydrodissection to find the pain generator of the patients. For dynamic ultrasound, for example, when you are facing a patient with anteromedial knee pain, I would say there is not many other modalities of investigations. We can ask the patient to do dynamic movements. Say the patient say that I only have pain when I'm going downstairs. Then you ask the patient to go downstairs, and then you do the scanning. But when we do the scanning of patient going downstairs, we're paying attention to the patellofemoral joint. Why the patellofemoral joint is the source of pain, or why the patient developed increasing friction between patellofemoral joint. So we ask the patient to going downstairs repeatedly, upstairs and downstairs, and then you can put the transducer bridging from the femur and to patella, and you try to pay attention to the friction, increasing friction between the femur, the femoral condyle, and the undersurface of the patella, and you also want to see there's any engorgement or increase in effusion of the suprapatellar pouch. And this is the same patient. The left side is painful side with, you can see the osteophytes over the femoral condyle. You can see the joint effusion with a lot of debris inside the joint fluid. And the other side, the right side, is a normal side. And you can see there is not much, maybe a little bit of the osteophytes, but not much effusion. So the same patient. For medial knee pain, if we have a cordless or wireless transducer system, we can ask the patient to walk on a treadmill. And then you can see during the swing phase, the protruded or the meniscus can sink back a little bit inside the tibial femoral joint. And you can also see a bit of osteophytes over the coronary ligament of the medial meniscus, and you can see a bit of increasing, a little bit of gathering of fluid around that coronary ligament, which may signify the patient eventually will develop like a meniscal cyst. Okay, and And you can see if the patient is really having some disruption in the attachment between the meniscus and the tibia. During the stance phase, it will be squeezed out. And you can still see a little bit of increase in effusion over the femur side, the femoral side. And then I would say we still need more study to show that how much protrusion of the medial meniscus is abnormal. And you probably can also see a little bit of disruption in the medial collateral ligament and the medial meniscus here, because you can still see a little bit of gap between that. So, and if we have a patient with anterior knee, and then I would like to scan the posterior part of the knee for a reason which I'm going to explain very soon when I was talking about the biotensegrity and fascia integrity. So this is a literature, and this is video you can find online. By the way, with all my presentation, if you see a QR code, you can scan that QR code to get a paper. So this is I think an easier way for people to get the paper and to learn something. And then when I do this hyperextension, and then with a little bit of flexion and extension, you can see the the PCL attachment to the femur. From the femur is inside the intercondylar groove, is having a little bit of laxity, and is a bit of a surrounding of fluid next to the PCL origin. And for the insertion part, you also can see a bit of a fluid collection as well. And also when I do this, and I try to find the meniscofemoral ligament, and which I think is very, very important for the lateral meniscus, integrity of that. And if I keep going to do the scanning, and by asking the patient to, sometimes asking the patient to move, and most of the time I would try to move myself. And with the patient, you can see the setting here is the knee completely out of the couch, so that I can freely move the PCL and the meniscofemoral ligament. In fact, we are also hyperextending the knee joint, and at the same time, we are also hyperextending the meniscal. Apart from the PCL, the meniscofemoral ligament, we are also hyperextending the obliquus popliteal ligament, and also if you go down a little bit, you're going to see the popliteus muscle as well. And then when we ask the patient to stand up, if the patient say that I have pain when I'm squatting down, or I have pain when I was walking, and I will ask the patient to stand on a treadmill or stand on a higher surface, so that I can ask the patient to do the semi-squatting. So if she's doing the semi-squatting, I pay attention to the integrity of the PCL and the meniscofemoral ligament, which is above and below the PCL, and also the obliquus popliteal ligament, which is right outside the joint capsule underneath the medial gastrocnemius. And so this is try to see whether there is any increasing disruption in the very compact fibular pattern, and also try to see any collection of fluid in between all those ligaments, which you can see a little bit around the meniscofemoral ligament and the joint capsule in this lady here. And then I turn the transducer 90 degrees this time. I can see the PCL from the origin, from the medial side of the intercondylar groove, and I can scan all the way down to the tibial insertion. Then I just pay attention to any collection of fluid right next to the PCL, and also between the PCL and the meniscofemoral ligament, or even between all those obliquus popliteal ligament. And you can ask the patient to walk on the treadmill and follow the the transducer is, you can see that I'm using a blocking technique with both of my hands. My thumb is blocking the one end of the transducer. Then I ask the patient to walk on the treadmill. And this time I want to see the integrity and also to see whether there is any disruption during the movement of this, the walking movement of the patient, to see the PCL during the swing phase and stance phase, especially paying attention during the propulsion phase of the gait cycle, and then to see whether the patient, why the patient developed the pain downstairs, and also develop pain anterior pain on walking, and why the patient has patellofemoral type of pain syndromes. So this is, I think, very important. And if you're interested in this type of videos, there are plenty of that in the Nysora apps. And then you can download the apps. And then we have dynamic ultrasound on the anterior knee, the lateral knee, the medial knee, and the posterior knee as well. And also, when we are seeing a patient with this type of laxity on the posterior knee, I would also like to see the nerve supply to these posterior knee structures, which is in fact the tibial nerve and the common peroneal nerve, or the common fibular nerve. So I will ask the patient to do this step, the plantar flexion and the dorsiflexion of the foot. And normally during the dorsiflexion, you're going to see the tibial nerve has been pulled, and during the plantar flexion, the common fibular nerve has been pulled, and that causes a seesaw type of dynamic movement. And this seesaw type of dynamic movement is so important because that's for the healthy movement of the sciatic nerve. And people who lost this seesaw type of movement, their sciatic nerve are not healthy, and the sciatic nerves and the branches are not happy, and then they are prone to develop neuropathy or neuromuscular dysfunction. Is one type of dysfunction of the popliteus muscle, and also all the muscle supplied by the sciatic nerve, and which is so important because that is for the protection of the knee joint and to prevent the knee joint from developing damage during the daily activities, and especially for those runners and bikers, and also for the hikers. So important, this. And then you can find this paper with the QR code I share with you here, and then see online on that. And then this is in fact one of my protocol to scan a patient with anterior knee pain. So this is so important. And even the patient with a medial knee pain, and then with developing the meniscal tear. But you remember, when you see a patient present to you with meniscal tear, with ligament laxity, ligament tear, those are consequences. Those are the results. Those are the pain that bring the patient to see you. But those are not the root causes. Try to find the root causes for their pain. And if you're facing a patient with, for example, a medial knee pain, and then you palpate the patient, and you found the patient is having some snapping. I think doctors here, you're listening to my talk. You can, when you're sitting in front of the computer screen, you can do this. Try to see this flexion and extension of your knee joint. See whether you are feeling any snapping on the posterior medial part of the knee. In fact, when I did that, you can see this gracilis is snapping between the sartorius and the semimembranosus, and the other side as well. So you can see this gracilis is snapping between the sartorius and the semimembranosus, and you can also see nerve fascicles pretty swollen here, because nerve fascicles here shouldn't be that obvious. And if you see a very obvious nerve fascicles underneath the sartorius, you probably are facing swollen saphenous nerve. And especially if this patient develop a pain in the anteromedial part of the knee joint, which is probably the infrapatellar saphenous nerve, which is having impingement. But remember, the infrapatellar saphenous nerve branch out here before the semimembranosus attach and before the adductor muscle attached to the adductor tubercle. So this is a very important landmark for you to do this saphenous nerve hydrodissection or treatment. And this, in fact, you also can use this QR code to get this paper. And the next thing I want to talk about is if you want to find a pain generator, you can use dry needling, or you can even use nerve stimulator. And to do the dry needling of nerve, I usually will pass a needle to the top of the suspected lesion and the bottom of the suspected lesion and try to use the dry needle above and below the so-called lesion. Or if that is osteophytes you're trying to do, and you can pass the dry needle right to the osteophytes and then to stimulate and then to see whether you can reproduce patients' concordant pain. And this is a technique. I use this dry needle just below the swollen nerve fascicle under ultrasound guidance. Then I pass a needle on top of that swollen fascicle using ultrasound guidance and right to that nerve swollen fascicle. And after that, you can see I'm trying to flickle the nerve. I'll try to flick the nerve, flick the needle, and then by vibrating the nerve, see whether I'm reproducing patients' neuropathic pain. So this is one of the skills you can use when you are facing a swollen fascicle. And of course, you can do a nerve block and then to block that nerve, and then you can also do a hydrodissection of the nerve. And I will take the following few minutes to illustrate how to do an ultrasound-guided hydrodissection of nerves. Basically, we have two skills. I call it method 1 or method 2. And the method 1 is using, is the needle always, also you can use this QR code to get this paper. Method 1 is the needle and the probe are short access to the nerve. And you're using in-plane technique all the time. You can pass the needle beneath the nerve first, and then pass the needle, hydrodissect the bottom of the nerve first, and then hydrodissect the top of the nerve. Reason for starting with the bottom of the nerve, because if you have any air in the needle, in the syringe or in the needle, and then the air, the post-acoustic shadow of the air will not block the view. So then you repeat the procedure by retrieving the needle back to the subcu and then reproduce and then redo another hydrodissection in the top of the nerve. And I would say it is the hydraulic force and it's the fluid, it's the injectate trying to separate the soft tissue in front of the needle. And the needle just follows the anechoic space created by the fluid. So you are not puncturing the structure, you are hydrodissecting the structure. So this is an example. I deliberately increase the speed of the video so that I can show you more. And this is a 5 times my normal speed of hydrodissection. I hydrodissect the bottom first, then I go to the top of the nerve. And remember, you can see I use the injectate to open the soft tissue in front of the needle, and then the needle follows. And this is another example that I try to hydrodissect and then let the fluid to open the soft tissue in front of the needle, then the needle just follows. And this is also a technique. You can use the same needle entry and to treat 2 or more nerves. Both of them are having some problem, and then you have to treat them together. They're running parallel to each other. The example is like the common fibular nerve and the lateral surocutaneous nerve and tibial nerve. They're running all parallel to each other. Then you can hydrodissect by going to the bottom first, then you go to the top, and hydrodissect each nerve fascicles one by one. And then usually you're going to hydrodissect at the most entrapped part of the nerve. And then you retrieve your needle back to the needle entry point, go to the subq, then you hydrodissect to the proximal part of the nerve and the distal part of the nerve. And by pivoting the transducer and also redirecting the needle. And so you can trigger longer length of the nerve. And the method 2 is your needle is in the long axis of the nerve, and you use in-plane and outer plane technique alternatively to check the needle placement. So usually you are approaching the nerve, and you can use the outer plane technique first. Then you use outer plane technique to hydrodissect one side of the nerve. Then you hydrodissect the other side of the nerve. When you see anechoic fluid is surrounding the whole nerve, and see at that time the nerve becomes rounded, then you put your needle back to the top of the nerve. Then you turn the transducer 90 degrees. This time you're using an in-plane technique, and you hydrodissect a longer length of the nerve involved. And then so the end point is you're going to see the nerve become rounded and no longer elliptical. And with all the mesoneurium, the soft tissue around the nerve, so most of the time they are scar tissues completely relieved by this technique. And you can map the nerve out so that on the skin by skin marker, so that each time when you do this turning, you know that in which line you're going to follow through. So you use outer plane technique first, and you can see the fluid is surrounding the whole nerve, and the nerve becomes rounded. Then you put the transducer back to the top. Then you turn the transducer 90 degrees. Then you can hydrodissect up to more proximal part. You can see the hypoechoic or anechoic fluid is also below the nerve as well. So this is another example that also the patient is lying sideline facing the other side, and then I'm hydrodissecting the common fibular nerve. You can see when the nerve becomes rounded, I put the transducer back to the top, and then you can hydrodissect to more proximal part. So that's the method 2. For this patient with saphenous nerve and entrapment, we just use the method 1, very easy, and then we hydrodissect these nerve fascicles out. But I have to remind you, this is a technique. You can prove the saphenous nerve is causing pain because of the snapping of the gracilis between the sartorius and the semimembranosus. But this is not the complete treatment for this patient, because this is only to prove the source of pain. But if you want to treat that, you have to treat the aproneurosis, the intermuscular aproneurosis, which is holding the gracilis to prevent the gracilis from snapping forward to go underneath the sartorius and the semimembranosus. And that's the treatment for the root causes. And next, I'm going to talk about the balance between the catabolic treatment and the anabolic treatment. And when we are facing patients' life cycle, I would say the younger the patient, the more functional the patient, we should use as minimal catabolic treatment as possible. And till the end stage of the patient, sometimes when we're treating a patient with like a cancer pain, like stage 4 osteoarthrosis, which if you're aware, recently we have a paper which I believe Dr. Tony Ng will talk about that. We have a neurolytic treatment for patients stage 3 and stage 4 osteoarthrosis of the knee joint. by radiofrequency ablation or alcoholic neuroablation. So which is catabolic, but that is the good choice for some patients to improve their quality of life. But when we are facing young patients, energetic patients, we try to use anabolic as much as possible. And for this regenerative, so-called regenerative medicine treatment, we can use dry needling, we can use hypertonic glucose, we can use isotonic glucose hydrodissection. Hypertonic glucose is a prolotherapy, and we can use platelet-rich plasma, alpha-2 macroglobulin, and bone marrow aspirate concentrate or adipose tissue aspirate concentrate, placental matrix or exosomes, which I'm not going to go into details. For example, when you look at the PRP and MSK pain, you just do a PubMed search. Last year, when I did this search for Dr. Sadiq's talk, I found 130 papers talking about PRP and MSK pain. But this year, I found there are 50 more articles talking about that, and 20 more articles, 20 more review articles, and also 7 more systemic reviews this year. So for the platelet-rich plasma for MSK pain, I have to say not all PRP are the same. So when you're reading the paper, the first thing I urge you to do is to look at how they prepare the PRP. I would say not all patients need a very high concentrated platelet, but the high concentrated platelet obviously gives more growth factors. And the study has shown that if you look at the so-called evidence-based medicine, you found we have abundant high-quality evidence to support the leukocyte-rich, platelet-rich plasma for lateral epicondylitis, or the leukocyte-poor PRP for osteoarthritis of the knee joint. And all the other conditions like patellar tendinopathy, plantar fasciitis, patellar tendon graft for ACL reconstructions, all are just moderate evidence. And the other conditions, even very common rotator cuff injuries, osteoarthritis of the hip joint, high ankle sprains, there is insufficient evidence to support usage of that. And we also have lack of efficacy, because the evidence show that there's a lack of efficacy for any other conditions like Achilles tendinopathy, muscle injuries, acute fracture, non-union, blah, blah, blah. So this is very frustrating. And even you look at some other papers, they are still talking the same. Evidence only support lateral epicondylitis and knee OA. And stem cells, also there are many more papers this year comparing to last year. Many more review papers, many more systemic reviews. But the result is the same. It's very frustrating because we only see patients, if we want to treat office-based mesenchymal stem cells, the only support for us to use the BMAC for this group of patients is only treating the knee pain. For any other treatments like hip pain, tendon pain, discogenic pain, there are reports, there are case reports, but further research is required. So which is in fact also frustrating. And very similar, any other studies talking about that. So most of the studies, systemic review show that with a small sample size, inappropriate control, short-term follow-up, and so on. So they only justify the use of all these for the knee pain. For exosomes and musculoskeletal pains, not many studies talking about that, and I'm not going to talk about this technique, but I think the cell-free therapies for chronic pain will be the target of study in the coming years. And the consensus for all this, all the conclusions from the evidence-based medicine is frustrating for all these biologics. There is no consensus how to prepare PRP or bone marrow aspirate or adipose tissue concentrate. And there's no consensus on protocol of regenerative injection therapy. And most of the studies only do one shot intra-articularly and do one lesional injection. But why? Why these very expensive biologics not better than dextrose prolotherapy? And you can see most of the studies only do one intra-articular injection, but which is in fact not the root causes of many problems. Just as I explained later on, early on and later on, you're going to see many of these. And most of the dextrose prolotherapy, in fact, are treating bowel tensegrity. And none of the regenerative medicine studies so far I found online are studying the nerve and to painful areas. And none of the protocols, including bowel tensegrity and fascia integrities and related nerves and fascia hydrodissections into considerations, which is also probably one of the reasons. When we look at the dextrose prolotherapy RCT literature, this is only up to 2020, but if you look at later on, if I have time to come back, and then I will update you about the dextrose prolotherapy research, which is, in fact, this summary was prepared by Professor Dean Reeves, my good friend, in Kansas City, United States. And you can see many level 1 evidence for groin pain, hip pain, knee pain, chondromalacia patella, osculocutalis disease, and ankle OA, plantar fasciosis, many level 1 studies talking about that. And so why? Why is that so? Even you look at one of the study, a very good study done by Professor David Rabago, and at that time also with Professor Jeffrey Patterson. He has passed away, unfortunately, and they have a very good paper published on Annals of Family Medicine, a very high impact journal. And then how they do this prolotherapy of knee joint study, apart from the intra-articular injection using 25% glucose, they also did extra-articular, peri-articular injection, very multiple spots into the tendon insertion, into the ligament origins insertions, and also to all those ligaments supporting the meniscus. So very important study, and take a look at that. And then you'll see their protocol and see their images. Then you probably will get a concept why we need to treat so many spots instead of just doing one shot intra-articularly. Why those one shot intra-articular injection not better than other prolotherapy, dextrose prolotherapy study? And in fact, if we want to increase the efficacy of your treatment, so-called a regenerative injection therapy to your treatment, try to treat the patient, but not to treat the image. And you try to listen to your patients instead of only looking at the images, and trying to really assess your patients by your hands instead of chasing the pain, but look at the patient as a whole. And think about bowel tensegrity, think about fascia integrity, and do the guided injection as much as possible, and correctly use the guided injection, and do your injection properly, and do the hydrodissection of nerves and fascia related to patient's suspected lesion before you do your RIT procedures, which is probably can improve the nerve supply and also the micro and macro environment of the region you are going to treat. Because I haven't had time to talk about why I would like to do hydrodissection first, but I just try to show you that when you're hydrodissecting the nerve, you're not only hydrodissecting the nerve. In fact, a lot of time, you also hydrodissect the arteries and the veins supply the region. And that means you also treat even the nervi nervorum, the vasa nervorum, which is the nerve supplying the main nerve, and the blood vessels supply the main nerve, and to try to improve the venous drainage, the lymphatic drainage of the area you're going to treat, and also to improve the macro and the micro environment of the region you are treating. That's the clue, and that's a very important the concept I want you to get tonight. So to assess your patient by hands, by physical examination, really touch your patient and palpate critically. And please do not only look at the X-ray or the MRI or the ultrasound images. And then try not to only look at, of course, don't look at the reports. And do look at the images yourself. For look, feel, move, and specific tests for any clinical conditions, for example, when this patient comes to see me for knee OA, for the other patients, this patient coming to see me and then with a knee pain, and I will ask the patient first to walk and to let me see. And then this patient present with right knee more than the left knee pain. Immediately I can tell the right glute max is not, the glute medius and the glute max are not firing, because the patient swing all the way to right side during each step when the right foot was on the ground. That means the right glute max are not firing. And if the patient is not firing the glute max, either the patient is walking with a Trendelenburg gait or the patient is swinging to the other side, which I don't have time to explain that much. Then I ask the patient to walk, and then I try to feel the patient walk. And the patient also feel a bit of the left knee pain, but it's more so on the right knee. And I can feel the patient walk, and there is protrusion of the medial meniscus on both sides, and more so on the right side, and the patient can tell, oh yes, I got the painful spot by the two fingers on the joint line, and my finger can really feel that meniscus protruding, and which the patient says, yes, that's the pain. Then I ask the patient to walk on a treadmill, and then I try to feel whether there's a patellofemoral friction, or whether there is any snapping of the tendons, or whether there's any engorgement of the popliteal pouch. And I want to feel which part is really having trouble. Then I ask the patient, the same patient walking on the corridor, to walk on the treadmill. Then you can see that during the swing phase, the patient's meniscus sink back to the tibial-femoral joint. And during the swing phase, the meniscus, during the swing phase, it sinks back, and during the stance phase, it protrudes out. And you can probably see a little bit of the gapping between the medial meniscus and the medial collateral ligament, which signifies a meniscal tear together with loosening of the attachment. And you can also see the detachment between the meniscus and the tibia. So think about biotensegrity and fascia integrity. Look at this needle towel, and then look at all the structures in your body: knee joint, ankle joint, your pelvis, your shoulder, your neck, whatever structures you're looking at. There must be integrity, which is holding the bones. And in fact, when we are in medical schools, we were taught that the muscles are moving the bones, moving the joints. But in fact, when you look at the idea of biotensegrity, the bones are floating in a network of the tendons and ligaments and all the soft tissues, the muscles and the joint capsules, the nerves, the blood vessels, and forming a network. And then for the soft tissue network, and for the bones to flow inside the network. So when you have one soft tissue get damaged. For example, you damage the ACL. Every single other structures is going to compensate. But the ACL damage is still a failure of the whole biotensegrity in the so-called integrity of the biotensegrity system. And you have to really to identify which structure is really having trouble. And that's the causes of the whole problem. And that's the reason why the patient developed the pain. And then you find the pain, you treat the pain, but you have to treat the root cause. For the fascia integrity, remember fascia is a magnificent network of transparent microtubules. And then within these microtubules, and you can see that they're interlinked with each other. And that forms the supporting structures. And then you have extracellular matrix with all this extracellular matrix floating within these tubules, and then supporting the structures inside this fascia. And even when you look at the tendons, the muscles, the nerves, the blood vessels inside the fascia, it is when each time when the tendons is moving, when you have contracting a tendon, when you pulling a nerve, and then it is this fascia is moving. And then within this fascia, you have soft tissue supporting the fascia. At the same time, you have extracellular matrix to allow the fascia to glide within that. And then the blood vessels are moving inside the fascia. The nerves are moving inside the fascia. That's why dynamic ultrasound is so important. That's why you need the gliding of the fascia. You have to treat the gliding of the fascia as the main treatment target. If you really want to treat the patient, you want the patient to resume their function and to regain their capability of walking, jumping, standing, and so on. For example, when you're treating a patient with patellar tendinopathy, which do not have very high evidence base, and these are the patient with anterior knee pain with walking downstairs. Try to think, when the patient walking downstairs, what structures should be supporting the patient walking downstairs? Could it be the quadricep muscle, hamstring muscle, the patellar tendon, the popliteal muscle, the popliteus tendon, the obliquus popliteal ligament, the arcuate ligament, the PCL, the ACL, the gluteus maximus, the medius, and all the structures, in fact, are working together to prevent you have a damage to the patellofemoral joint, to prevent you have a damage to the patellar tendon, and so on. So when you look at the patient, when you do a scanning, of course, you are going to scan. If a patient with a jumper's knee, you're going to see, oh, the patellar end of the patellar tendon is having increase in thickness, disruption in compact fibular pattern. There is increase in neovascularity, increase in hypoechogenicity. But those are the signs for you to make a diagnosis of patellar tendonitis. But and also for osgood-Schiller's disease, you can look at the tibial insertion. Then you see all these structures. But are these the root causes of the pain? Then you ask the patient to lie prone, and with this, you have seen this before. Why? Why anterior? And you have seen this before. Then I ask the patient to lie prone. In Taiwan, they call this Stanley Lam. Initially, I thought this is PCL laxity, but now I realize it is all the structures with hamstring, the obliquus popliteal ligament, the arcuate ligament, the meniscofemoral ligament, the PCL, the joint capsule, the popliteus, everything posteriorly is not functioning, even the ACL are not functioning well, then the patient develop this laxity with the dropping of the dysfunction knee and dysfunction leg, and then forward. So this is when you see that, this is the left side of the knee is painful and is having the anterior problem. So this is the patient develop anterior knee pain on the left side, but not on the right side. And the patient is completely relaxed. And then I scan that. And I will try to do this hyperextension to see the PCL and the obliquus popliteal ligament and the meniscofemoral ligament laxity. And I try to do a posterior Lachman test and to see the integrity of the PCL. And then I try to see this is meniscofemoral ligament is also having some laxity in here. Just this is a posterior meniscofemoral ligament. Then I ask the patient to do this posterior Lachman again, and then lying prone. Then you can see a debris, which is a disruption of the cartilage, which is floating from the meniscofemoral ligament, between the meniscofemoral ligament and the PCL. So which signifies something has damaged. Then I scan the patient and do the transverse view, and you can see that loose bodies very soon. And at the same time, you're going to see the medial root of the meniscus, which is on the medial side of that right here. This is the root of the medial meniscus is having some laxity. You can see a bit of on the medial side. So that's something which is I have to pay attention to. I have to treat all this before I can treat the patient well. And I hyperextend the patient and to see whether I can see this the loose bodies. I can see the laxity, and then you can see this one is much lax than the right side. The left side is much lax than much loose and lax than the right side. So treatment of the anterior knee pain, of course, I have to treat the anterior side, but to treat that, I urge you to hydrodissect the anterior femoral cutaneous nerve before you really go into the tendon, because those are the new nerve that carries the blood vessel to supply the tendon. And that's why I will hydrodissect outside the tendon first and to treat the anterior femoral cutaneous nerve. And after that, then I go into the tendon, and then I really to inject into the tendon rupture part and to treat this is to treat the pain and treat the consequence. Remember, this is to treat the consequence, not to treat the root cause. But you have to treat the consequence and treat the root cause at the same time. So you have to treat both. And after treating the consequence, then I go back to treat the root cause, which is to treat the posterior structure, the PCL, the meniscofemoral ligament, the ACL, and to treat the obliquus popliteal ligament. And you can see how lax when I'm injecting the PCL here. It's very lax. And normally, when you're injecting into a normal PCL, it should be very, very stiff, and it should be it should use a lot of force to inject instead of just injecting freely. And then I go to the meniscofemoral ligament and also injecting the obliquus popliteal ligament. And for this patient, even when you inject to the PCL, you can see the flow of the fluid and all the way to the biggest cyst, which is absolutely not going to work. And if you only treat the bigger cyst, so I have to treat both of them, and also to treat the whole PCL, and at the same time to treat the root of the meniscus, which is in fact the root causes for the bigger cyst. Okay, so what's the time now? Sati, do we have time to keep going a little bit more? Maybe 10 minutes. Okay, so
Please do.
no, No objection means good. Okay.
I don't think, people are glued to their chairs. So carry on, please. And I'm glued
Carry
too.
on. Okay. I can still see some doctors are logging in. So this, which is I
It's a
think is
good
good.
sign. It's a good sign. You carry on, Stan. That's great. Thank you so much. Thanks a lot.
Okay. So when we are facing another group of patients, totally completely different groups of patients, interscapular upper back pain. And in fact, when you're facing a group of patients like that, I would still think about the original thinking we have had before. Is you have to find out which is who are the pain generators and what are the causes of that and how to treat that. For interscapular pain, it can be the dorsal scapular nerve, it can be the rhomboid trigger point, it can be the facet, it can be a lot of things. And for thoracic facet, and I don't think we have time to go through the very detail of all this, but in fact, this is a video which I teach how to scan the whole thoracic spine muscular structure from the upper trapezius to mid trapezius, all the way down to latissimus dorsi and the multifidi, longissimus, iliocostalis, and how to find the serratus posterior superior and the rhomboid. So I don't have time to go through that. Maybe later on we can have one section to talk about the sonal anatomy of the spine. So which this is another view. But I will quickly show you one very, very important view like this one here. Why I show this one? This is the second rib. And you can see on the second rib, you can see this is a dorsal scapular artery, and the medial to that is the dorsal scapular nerve. And you can see a muscle which is attached to the second rib, which is the serratus posterior superior. And medial to that, you have the iliocostalis muscle. And medial to this insertion, you have a nerve which is called the posterior cutaneous branch of the spinal nerve. In this case, is the T2. And you have the dorsal scapular nerve right outside or lateral to the insertion of the serratus posterior superior muscle, which is medial to the dorsal scapular artery and underneath the levator scapulae attachment. And if we keep going down, you can see this is a transition between the levator scapulae and the rhomboid minor muscle here, right here. This is a already transition from, this is still the levator scapulae. So I'm going cranial. So if I go caudal here, so if I keep going caudal, you can see this is from levator scapulae, and now levator scapulae, rhomboid, levator scapulae, rhomboid. Okay, so never mind. So I will talk about that later on if we have time. But you remember, this is the dorsal scapular artery, and the serratus posterior superior insertion is the landmark for you to find the dorsal scapular nerve. And you also see this is trying to do a sagittal view of all those muscles, and from the ribs, from the facet, lamina to transverse process. And this is the facet joint, and you also see a little bit of the epidural space if you're tilting that medially, and then it could go back to the transverse process and all the way to the ribs. So which is, I don't have time to go into details, but I would like, because I want to, this is not a sonal anatomy lecture, I would like to illustrate the concept here. Okay, so when we are facing a group of patients with interscapular pain, and the thing of the structures, if we look at here, between the scapula, we can see we have the middle trapezius, mid trapezius, you have the rhomboid, you have the serratus posterior superior muscle, and you also have the iliocostalis longissimus, you have the semispinalis capitis all the way up, if it goes from T6 upward, and semispinalis surfaces. We have a spinalis capitis, and it's a splenius capitis. You also have the multifida muscle. So these are the muscles inside this medial to that. So you have the transverse process, you have the costal transverse joint, you have the facet joint. All these can be the pain generators. And after doing this, you probably can do the dry needling to the facet and to the muscles, and then you can see how maybe you can get to the target. You can do a hydrodissection or block of the facet joint, and you can do multiple levels within one needle hole, and then you can do 1 level, 2 level, 3 levels using a different length of needle, and then to do that. Okay, this is you can use cranial to caudal technique with ultrasound guidance. You can also do the caudal to cranial, cranial to caudal. So doesn't matter to me, and but because you see the needle tip all the time, and then you want to do the facet joint injection. And remember, this facet joint injection is also for the multifida, because multifida muscle is covering the facet. And you can also do, I think this one is wrongly placed here. There should be another one. I would just skip this one first, and then later on. And for the dorsal scapular nerve and interscapular muscle, so when we look at this dorsal scapular nerve, remember, in fact, the entrapment point, most of the time, above the C, not only above the C2, it is also when the dorsal scapular nerve comes out from the C5 and the passing through the middle scalene. So this is try to use a dry needle within the middle scalene, and then I try to stimulate the dorsal scapular nerve, because I want to prove whether the pain is coming from the middle scalene or is coming from the interscapular, not dorsal scapular nerve, even you suspect that is the nerve. Or if you know how to scan that, you will want to find the insertion of the serratus posterior superior muscle, and medial to that, you can see that this is the dorsal scapular nerve. And then we map the dorsal scapular nerve, and we can do an injection. And you can also use this QR code to get this step by step with this picture here, and then you can find this paper online, and then you can see the technique I have used for this hydrodissection of dorsal scapular nerve. But I would also like to introduce to you another structure which is also causing the interscapular pain if the patient, especially if the patient, you have treated the dorsal scapular nerve, you find the dorsal scapular nerve not working, and you find the patient does not have any trigger point within the rhomboid, within the multifida, within the levator scapulae, within the middle scalene, nothing. And you find the patients having whiplash injury before, you find the patient with bilateral onset of interscapular pain, not only on one side. Then you look at the disc, which is not, the cervical disc, which is not as pretty as this one, because this is a teenage. Okay, you can see this is the disc, and that's the spinal cord. You can see the pulsation of the spinal cord, and this is the thyroid and the carotid artery. And this is a young patient as well, 20-something, and then it's a completely normal cervical disc, and it's with a spinal cord pulsating, a thyroid, carotid artery, the omohyoid, a stylohyoid, and also this SCM, and also the another one. So you can look at, you know how to find these structures, and then you know when you turn the transducer 90 degrees, this is a normal intervertebral disc of the cervical spine, and this is C6, 7, and C7, this is a C5, 6, and 4, 5. So you can see normally there shouldn't be any bulging, there shouldn't be osteophytes, and you should not see osteophytes like this. This is a normal And then you can see this is the bulging disc together with a ruptured disc. Then I ask the patient to rotate the neck and head. I would like to pay attention the debris inside the disc. You can see the debris inside the disc here when the patient is rotating the neck, and then that signifies a ruptured disc. And also, this is the right side of the disc, and that's the left side of the disc. This is spinal cord here. And after doing this rotation, then I ask the patient to do the flexion, the rotation again. This time I would like to pay attention to the disc again. And you can see the osteophytes. I can see the ruptured disc with the debris inside. And I can ask the patient to do the flexion and then try to feel to see the debris moving. And also you can see the very narrow disc. And this is pretty much like a fused disc. So you can do a digital palpation of the disc between the thyroid and the carotid artery. And through that longus colli muscle, you can feel the disc. You can reproduce patient's pain. If you're reproducing patient's pain, then that means you have done a good job. That's the disc you have to treat. So this is how you can, I'm palpating the C6-7 disc, and through the omohyoid and longus colli and the SCM, and then palpating the C5-6 disc, and then through the longus capitis, longus colli, and then also to the disc, to the anterior surface of the disc. And remember, when you do this palpation, the reason why I feel you can reproduce patient's pain is because you have you're really try to squeeze the disc a little bit, and that creates discogenic pain, reproduce the discogenic pain. Okay, so I go back to this disc later on, but I have to finish the hydrodissection of the dorsal scapular nerve. This is the approach you can using the in-plane technique, and then in the long axis of the dorsal scapular nerve, lateral to the dorsal scapular artery, and you can hydrodissect like that with the patient side lying. And this is not very ergonomic to your neck. I would like to introduce this massage chair for you to do in your clinical practice. I have my patients lying on the massage chair. Then I can use this in-plane technique in the long axis of the dorsal scapular nerve, lateral to the dorsal scapular artery. You can do this hydrodissection of the dorsal scapular nerve. This time you can facing the ultrasound machine, very ergonomic. I don't have neck pain after that. The previous one, I have neck pain after that. Okay. And this time, you're going to do a hydrodissection, and this time is in the short axis to the dorsal scapular nerve, and then your needle is coming from lateral to medial, and then you're hydrodissecting on the lateral surface of the serratus posterior superior medial to your dorsal scapular artery. Then you can hydrodissect. Also, I probably said the wrong thing before. Remember, the dorsal scapular artery is on the medial side of your dorsal scapular artery. Sorry for confusing you. If I said when we do this long axis approach, okay, your needle should be medial to the dorsal scapular artery. And this time, this is a approach. You can also treat the posterior cutaneous branch of the spinal nerve. It's much better. You can treat several targets at the same time. It's much better. Okay. You can even treat the costal vertebral joint, which is on the medial side, and you can treat that. You could treat all the way to the dorsal to the costal transverse joint, and to treat the medial and the lateral branch of the spinal nerves, dorsal rami of the spinal nerves. You can see that I'm treating the costal transverse joint as well. And after that, and then finish the treatment. So you can treat so many targets: dorsal-scapular nerve, the posterior cutaneous branch, and the medial branch and the lateral branch of the spinal nerves. And at the same time, if I still have some fluid, using the same needle hole, I can also treat the spinal accessory nerve underneath the upper trapezius as well. So this is one stone, several birds. And then also for the interscapular pain, if I'm using a supramedial approach, you can treat from the medial to lateral. And this time, you can see the needle is coming from the medial side. Then I'm treating the dorsal scapular, the spinal accessory nerve underneath the upper trapezius. And you can also treat the levator scapulae attachment for muscle trigger point or tendinosis. And you can also treat all the way to the attachment of the levator scapulae on the medial surface, supramedial surface of the scapula. Then I go to treat the dorsal scapular artery and the dorsal scapular nerve. And after that, I go more medial to the serratus posterior superior muscle. Then I will treat the spinal, posterior cutaneous branch of the spinal nerve right here. And then you can see I already treated the spinal accessory nerve. Then you can turn the transducer into the sagittal plane, and you can treat a longer length of that, or can treat more branches of the spinal accessory nerve underneath the upper trapezius all the way to the front. So basically, it's a one bird, one stone, several birds. Okay. So this is basically, I combine all the technique to treat multiple structures at the same time. You can even pivot the transducer more medial to treat the costal transverse joint of the first and the second rib, and then which is also a very, very important, which is causing the upsleep of the first and second rib, which is causing a lot of the so-called the dorsal scapular nerve on top of the second rib. So you can treat the costal transverse joint. So all within one needle hole, you can treat everything. Okay. So for this is in fact a sketch for a patient present with an interscapular problem or neck problem or suboccipital problem, and this is all the targets for the prolotherapy, hypertonic glucose prolotherapy, which is in fact this picture you can get from Dr. Felix Linetsky's chapter. Try to email me. I can send the paper to you. So for that patient with this so-called the pain in the, if that is coming from the transverse process all the way up, you can treat all the transverse process. You can treat the costal transverse joint, and you can treat the spinal, the semi-spinalis capitis origin from the transverse process up. You can also treat multiple levels within one needle hole for all these. And this is in fact I've said that, and then you can treat all the muscles in the lamina all the way down to facet, and also treat the costal transverse joint by one needle hole, and then you can do everything. So this is the hypertonic glucose type of injection. So because they inject so many spots to treat the so-called bowel tensegrity. Okay, and then for a patient, the uncovertebral joints are not tall, and then we can use a technique which I have published 2 years ago, and with needle coming from the SCM underneath the internal jugular vein, and then through the serratus anterior, and then go all the way through the longus colli, and then to the center of the disc. And this is the patient is facing up. You have a roll of towel underneath the neck and the upper back, the hyperextended neck, and then you can see the needle hydrodissecting the SCM, and through the anterior scalene and the longest coli, then you can go to the disc. And then you turn the transducer, you can validate the needle entry, and you can use using a fluoroscope to validate the spread of the dye. But I would say for every single disc injection now, for the cervical disc, I try to not to add any local anesthetic first, because I want to see whether the needle is reproducing, or the injectate, for example, the PRP is reproducing patient's pain, and then after that, then I add a little bit of local anesthetic. So you can use the PRP because we have validated the spread of the dye. So I no longer use a fluoroscope to do the cervical disc. I just using PRP to do the disc injection to validate, and then to also to reproduce patient's pain by injection. And after that, I just adding a little bit of local anesthetic to take away the pain and to let the patient have relieve their pain, and then the patient will say how many percent of the pain is getting better. So a lot of time the interscapular pain, if that is really coming from the disc, and if you're reproducing the disc by injecting PRP first, then you do a bit of local anesthetic, and then you take away the pain, and then they will just love it. Okay. And if the patient is having a very tall unconvertible joint or very significantly degenerated neck with a very tall osteophytes, which obstruct the needle pathway, the trajectory of the needle from lateral to medial that much, then I will be using a medial approach. The needle will be hydrodissecting through the SCM, sometimes through the omohyoid muscle, and then through that between the space of the carotid arc, carotid sheath, and the thyroid gland, or the thyroid cartilage, if that is above the C4. And then I hydrodissect through the prevertebral fascia and through the longest coli muscle to get into the nucleus through the annular fibrosis, the nuclear pulposus. So you can see this. This is the approach. We hydrodissect, and you can use 2-needle technique. And then the first needle just hydrodissect to the prevertebral fascia. Then after that, you use an inner needle, spinal needle, and then to get through the longest coli and all the way to the annular fibrosis. And after that, then I change to PRP. I'm using the 5% dextrose only to hydrodissect through these structures. And then as soon as my needle enter the disc, I change the syringe to PRP, and then I will turn the needle, turn the transducer 90 degrees, and we'll try to validate the needle to get into the nucleus, to the annular fibrosis, and about 1 centimeter, and then you're going to enter to the nuclear pulposus. Then I'm going to inject PRP, and to see whether the injection of the PRP will reproduce patient's concordant pain. So if the concordant pain is reproduced, I will ask the patient to see, to grade how many percent of the concordant pain is reproduced. And then before that, I will palpate the disc, of course, by using the digit. And after that, if this is not reproducing all the pain, then I will probably have to do another level, like the C6-7 and C5-6 are the 2 levels I usually need to inject. And this is another technique using the in-plane technique. And then, but the best way to do with this technique is you can use a micro-convex transducer. Again, the same technique, same needle pathway, just this time you're using an in-plane, you have to put your transducer more medial, and as soon as the needle touching the outside of the disc, then you turn the transducer, then you can redirect the needle finally to get into the disc and then do the injection about 1 centimeter into the nuclear pulposus and then do the provocation and also to do the injection. And this is the microconvex transducer, and then you can see the carotid artery and the thyroid gland has been pushed away by the pressure of the transducer, which is very good. And then you can do a hydrodissection much better with a much better view of the needle. Then you can hydrodissect through the prevertebral fascia and then get to through the longus colli and then to the annular fibrosis. As soon as the needle to the edge, then we're going to turn the transducer 90 degrees this time. And after turning the transducer 90 degrees, then you can see we can redirect the needle finally to get into the disc. Then you can do the injection very well to the center of the disc to see whether you're reproducing patient's pain. And with this transducer, because of the penetration, you also see the spinal cord on the other side of the disc. This you can see the whole disc, you can see the spinal cord, and then you can do the injection very well. And with a technique, some machine, ultrasound machine with super microvascular image, then you can see the spread of the injectate very well. So to summarize this today's lecture, I would say the new concept of pain medicine is we want to find the pain generators. We want to identify that, but we have to really to think about what are the root causes of the problems. The pain generators may not be the root causes of the problems. And we try to use anabolic therapy to the patients as much as possible, unless we're facing a specific group of patients facing the end stage of their life. And we try to use bowel tensegrity and the fascia to think about what structures we're really treating. And we try to use regenerative injection therapy as effective as possible. And I welcome you to download this app and to try that. And after that, and then give me feedback about that. And if you really want to learn something about that, apart from what Dr. Sadiq has mentioned, the workshops next year in the end of June, I welcome you to Hong Kong in the Chinese University of Hong Kong. We're going to have fresh cadaver workshop, and I'm going to teach all the techniques of hydrodissection, regenerative injection therapy, and the disc injection, and so on. So thank you very much for your attention.
Thank you so much, Stan. That was an amazing lecture as usual. I can tell you, every time I listen to you, so much to learn. Now, Stan, can you stop screen share so we can see your face and we could take a couple of questions? And I must say, look at the interest. It's Sunday evening and we have more than 80 people tuned in, listening to you throughout the 1 hour and 25 minutes. Okay, so that just tells you how
Thank you.
people
Thank you, all of you.
in the topic. And let me now quickly get on to the questions. Okay, now a couple of questions you've already answered. Okay, so we'll go in the reverse order of the questions. So question one from my good friend Modar Choker asking, how much volume of PRP would you inject for discogenic pain?
So for the cervical disc, it's not much. It's just like about 1 to 1.5 cc about for cervical disc. For lumbar disc, you can inject up to 3 cc.
Okay, right.
But of course, as I would say, in fact, I like to see how patients feel. That's why in the disc, initially, I will not add on any local anesthetic. I just using slowly injecting the PRP into the disc, because that's a leukocyte poor, RBC poor PRP. Then I asked the patient to grade the pain I reproduced. Number one, the location of the pain, whether that is reproducing that discogenic pain, or whether that is the same similar type of pain. They are the nature of the pain is similar to their usual pain. Number three is the degree of the pain, whether that's this is the exact nature, locality, but it's only 70%. That means I can push a bit more. If that is a totally different type of pain, so I will stop. Even just a tiny bit, I will stop. Just forget about that. Okay. But usually after palpation and you do this injection, you increase your accuracy a lot more. And if say this injection is already just tiny bit, you already, because some of the disc, they are just desiccated, they just ruptured, but they cannot take so much volume. So you're just injecting about 0.5 cc, and they already say, oh, that's exactly my pain. Oh, that's how severe was the pain? Oh, it's almost, it's 100% of the pain. So only a bit, stop. Don't do that. Don't keep injecting. So it's really individualized, I would say.
Okay, great. Next question we have is, a couple of people have asked about the recordings. So guys, the recordings, I'll try to put them on the YouTube channel for the Pain Talks. We wanted to do Facebook Live, but we couldn't for some reason because, there have been technical issues. But you can subscribe to the YouTube channel of Pain Talks. Just go into YouTube and type in Pain Talks. You will see the Pain Talk logo, and we will put the recording there. Now, Stan, there is a very interesting question on this, that when you treat fascias, you're trying to improve integrity, or trying to regulate the function of the nerves in the area, or trying to do both. So do you think we're doing both? We are improving the tensegrity, and we're also improving the function of the nerves?
Absolutely. That's in fact to treat the fascia is in fact you're treating the everything. In fact, you treat the nerve, the blood supply, you treat the bowel tensegrity, the motion, the mechanical motion of the integrity motion of the joints or the bones, the muscles are acting on. In fact, take shoulder as an example. If you don't know how to treat the fascia, it's very hard for you to treat the shoulder pain or the so-called pseudo frozen shoulder. In fact, a lot of shoulder pain, even the tendinopathy, even they have rotator cuff tear, those are the consequence. The problem is a lot of time is from the fascia, which is holding the scapula in the scapulo-thoracic movement. Is so important. And that also regulates the nerve supply, the muscle holding that. So that also regulates the dorsal, the thoracodorsal nerve, which is supplying the latissimus dorsi muscle and holding the scapula from as you remember the examination talk I gave to you before. And then that's, in fact, if you don't know how to find the scapular movement and to see the fascia, which is really holding the scapula in the scapulothoracic harmonics. And then if you don't know how to treat that, it's very hard to treat the shoulder pain. And because all those rotator cuff tear or the snapping shoulder or the so-called impingement of the suprascapular nerve, all of those, in fact, are secondary. They are basically a failure of the bowel tensegrity and the fascia. So to treat, I was trying to to treat the whole fascia, the integrity of the fascia, and then I treat the bowel tensegrity. And that's also the reason why when you look at the traditional prolotherapy textbook, and then talking about how to treat shoulder biomechanics, is they inject along the whole circle of the scapula and inject the spine of the scapula They even inject the clavicle, and they inject the medial border, the lateral border, and they also inject the spine, the spinous process of the spine, and also the transverse process of the spine. And that those are in fact so important, very important structure for the fascia and the scapular fascia, or the infraspinatus fascia, which is holding the scapula in place. So to summarize, to treat the fascia, whatever fascia we are talking about, or even when we talking about this the snapping gracilis between the sartorius and semi-membranosus, it is in fact the intermuscular fascia or the intermuscular aponeurosis is having trouble. So that's the reason why the gracilis is starting to snap between the sartorius and the semi-membranosus. And that's also the reason why the patient got saphenous nerve entrapment. So when we see, excuse me, when we see all those snapping, when we see all those entrapment, we have to think about why this patient developed this problem. There must be a cause. There must be an underlying cause for us to do this. I hope as a group of doctors here, we can treat patient earlier instead of waiting the patient in the end need surgery, or in the end need our good friends Dr. Jojo to put this so-called spinal cord stimulator into the spine to treat that, or to prevent the patient to end up in Dr. Tony Ng's hands doing the neurolysis for that. So I think those are the very, very important techniques to improve quality of life for so many patients, for so many end-stage patients, and so many failure of spine patients. Very important techniques, no doubt. But before that, when we are treating a whole other group of patients, they are younger, they're active, why don't we think about each time when a patient come into our office, observe and do take a good history, and to ask the patient why you develop this problem. Ask yourself, why this patient developed this nerve entrapment? Why this patient developed this tendinosis? Why this patient developed this muscle tear? There must be a cause for that.
2 seconds, Stan. Let me mute all. Yeah, Stan, now you can unmute yourself. I think, guys, please mute yourself. It just disturbs the flow. So I think it makes a lot of sense, Stan. As you said, we need to focus on, muscle, tendons, ligaments, fascia as a whole unit, rather than just treating an individual structure, because the disturbance in the biointegrity model is so important. And I would say a lot of times people say, what trigger point injections, what kind of intervention is that? Always think when you're doing trigger points, you're not just doing a trigger point injection, you're also doing fascial release. So for example, simple treatment like trigger point injections, I always not only just injecting the muscle, I will go between the fascial layer of, for example, spinatus, because I want to make sure I flood the whole fascia and try and release the pressure, and try to kind of improve the circulation to the muscle as well as to the nerves. And eventually, even a local anesthetic injection is good enough to treat the myofascial component, because you're doing a fascial release. You don't need steroids all the time. So I think that's my take on it. We will have one last question, and I think you've already answered the posterior knee pain and the the Baker cyst treatment. You need to treat the cause to treat the Baker cyst. So you already explored on that, and you showed us injecting the PCL and injecting the ligament, and that's the treatment for recurrent Baker cyst. Unless you treat the cause, you're not going to treat the Baker cyst. There's always going to be accumulation of the fluid. Last question is, in the interventions of discography, we always have a discussion whether or not to inject antibiotics. And what's your take on this? Do you inject antibiotics? And do you do and if you're doing intradiscal PRP, how many times do you repeat it? So antibiotics, and how many times you repeat the PRP?
Okay, good question. In fact, I tried to do pre-injection either your intramuscular or intravenous third generation cephalosporin group of antibiotics. And you can do one bullet shot 30 minutes before the procedure, which is I think the standard procedure for people doing their discography. And so that's to play safe. And I sometimes I will also the whole tract of the needle before especially if you're using a 2-needle technique. For the first needle, introducing needle, you can use using a bit of antibiotics to do the introduction. After the first needle, the second needle, because it's inside the first needle. For example, the first needle is like a 20 gauge, 1.5 inch needle, and the second one is a 25 2-inch spinal needle. Then you can just insert the spinal needle all the way to the disc without any antibiotics. But the problem is, even with all these, you have to tell the patient discitis is still a real danger. It's still a real risk you have to face. The reason is simple. Even some of the patients, they have all these procedures done in operation theater. They have a whole aseptic technique. They have done this this pre-procedure antibiotics. But the problem is, some of the patients, they already have some bacteria colonized in the disc before you introduce a needle. And that's also the causes of some of the mordic changes. And then if you introduce a needle to those discs, you're going to introduce trouble to that. And the patient will just will just say, okay, because of the needle you introduced, then you introduce the bacteria. And so this is a real danger the patient have to face, and you have to explain that to the patient again and again. Each time for the informed consent, you have to say that discitis is a real risk, is a real possibility of any disc procedure. And for how many times of PRP injection, it really depends on patient's severity. For like a patient is, in fact, my experience for hundreds of patients is like, in fact, the severity of pain does not correspond to the numbers of treatments the patient needs to have. Sometimes the patients have very severe pain, but only one treatment, the pain is gone. Yes. Because the pain from the discogenic pain usually is when the patient started to have desiccation and the disc first rupture, or when the materials is trying, especially that is a refer pain all the way to the so-called interscapular region, because that's the patient started to feel the desiccation. And then they develop the disc. Usually, I would say for any regenerative injection therapy, I will review after 3 injections. That's a number of it's a rule of 3. After 3 injections, if there is no response, you have to change. If there is lack of satisfactory response, you have to change your protocol. And I would say most of the time, my patients, after 3 times of PRP injection to the discogenic pain, most of them is getting much, much better. And then I would just ask them to come back if they in a PRN basis, as required basis. So that's my protocol for that.
Level between the 2 injections, Stan? Are you doing it at like 6 weeks, 4 weeks basis, or what's the interval?
Yes, it's because the growth of the soft tissue is like 4 to 6 weeks. But for the disc, because it is the blood supply to the disc is so poor, so the regeneration power is so slow. So you probably have to wait a bit longer than like a knee joint, hip joint, other parts of the joint. And so I would say for the cervical disc and then the lumbar disc, I will follow up and then repeat the procedure like a 6 to 8 weeks.
Sure.
But for other parts of the joint, I would like to repeat in 4 to 6 weeks, unless the patient is coming from other parts of the world and they stay in Hong Kong and then they want to leave Hong Kong maybe a bit earlier, and then I would just shorten the interval between the injections. Yeah.
Great. Thank you so much, Stan. That was an amazing, I would say, productive use of my evening, and I'm sure a lot of people have found that useful as well. So, as I said, few announcements. 2023 in June, be there in Hong Kong if you want to learn the ultrasound applications for examination of the joints as well as injections. So I'm sure that's going to be a very, very good course to attend. Next week, I'll see you guys once again on Pain Talks with Prof. Admir Hadzik, who will talk to us about the building the teams and also future of learning. And I will try and put this talk on the YouTube channel of Pain Talks, and do join the Facebook group, guys. We have a Facebook group of Pain Talks, and I will make Dr. Mattis, Professor Lam, and Dr. NG as admins, and they should be able to add you guys as well. And do reach out to us. The email address is paintalkseducation@gmail.com. We are not able to give you the certificates. I can't print 78 certificates, so, and there are no CME points. This is entirely pure educational talks, and we will basically keep this very much kind of, a discussion based, an education based platform. So do apologize. I'm the one-man band at the moment. These guys are helping me with the talks, but I'm not able to send you the certificates. So do apologize, but I'm sure you will be able to get a lot of education, a lot of good points, a lot of scientific kind of material through this platform. So thank you so much. Stan, anything you want to add? I must say, I appreciate you giving your time. I know it's about 10 or 11 o'clock in Hong Kong, so thank you so much for staying up late. And Tony, thanks for joining us all the way from Australia. Tony's probably awake, and it's about 2.
Yeah.
So
I would say the skills and the knowledge we as a group of doctors want to share within this platform is to help as many patients as possible. So try to learn that and try to really to test on silent teachers first. If you want to learn the technique and then you want to do the so-called disc injection well and do this hydrodissection well, especially you're trying to do the method 2, try to practice that on the silent teachers, and because they're not going to sue you and they're not going to complain, and then you can do as many times as possible. But try to not to after listening this and tomorrow and then back to your office and go to do this injection right away, which is dangerous. Okay, so thank you very much for your attention, and thank you, Sadiq.
Oh, thank you once again. So guys, have a good rest of the evening. As we said, this is a knowledge part we are imparting to you. If you want to learn the skills part, you attend the cadaver course, or you attend the physician who's doing this procedure on day-to-day basis. Go and spend some time with them, see how they're doing this procedure, and learn from them. Practice on the cadavers before you do it on the live models. So thank you so much. Have a good evening, guys, and I'll see you next week. And we have many talks lined up. As I said, the whole physicians from Cleveland Clinic Abu Dhabi are going to do the talks one by one, and you will be able to get a lot out of Pain Talks. So thank you so much, and good night, everyone. Bye bye now. Bye.